Hi, I'm Stephanie Shelton, and this is episode 42 of Conversations on Health, How We Get There. Under Robert F. Kennedy Jr.'s stewardship, the CDC, once the premier health and health data organization in the world, continues to shed scientists, physicians, researchers, and internationally respected leaders. As I record this in early March, the CDC still doesn't have a presidentially nominated and Senate-confirmed director. And although much of the agency's basic public health information and professionally recognized studies remain available on the CDC website, much is also gone. Among the missing at the CDC is my guest on this episode, Dr. Karen Hacker, who headed the National Center for Chronic Disease Prevention and Health Promotion. Remember, the main purpose of both federal and state health agencies is implementing and overseeing ways of improving the health of all Americans, thus the term public health. And remember also that in terms of outcomes for money spent, the U.S. continues to have the lowest life expectancy and the highest rates of preventable mortality among high-income nations. And that's despite spending nearly twice as much on health care. One major but very complicated goal is finding, or at least drastically cutting, chronic disease. Diabetes brought on by obesity is one example. Lung cancer or COPD is a result of cigarette smoking. That's another. So, as I said, we're all very fortunate that Dr. Karen Hacker, with all her experience, is here for this conversation. Dr. Hacker, who has both an MD and MPH, is an adjunct professor and health policy fellow at Emory University in the Rollins School of Public Health. She's the former director of the National Center for Chronic Disease Prevention and Health Promotion at the CDC from 2019 to 2025. Dr. Hacker has over 2 decades of leadership experience in the public sector, serving at the city, county, and federal levels. Her expertise spans public health policy, health care, and research. Prior to CDC, she was the director of the Allegheny County Health Department in Pennsylvania. She's also widely published with over 100 peer-reviewed articles and an expert in community-based participatory research. And there's much more, which we'll put in the show notes. And as usual, we use first names in this informal conversation. Karen, thank you so much for coming on the podcast. This is really, really interesting.
Glad to be here.
So I know you are one of the doctors and scientists and researchers who, for one reason or another, are no longer at our CDC, which is a sad thing for public health, I think. Your story, what was your story?
So I was the director for the National Center for Chronic Disease Prevention and Health Promotion until April 1st, when I got an email that basically said, you are being reassigned or voluntarily reassigned to the Indian Health Service, and then you're going to be put on administrative leave. So I was basically told to go home. I was still getting paid, and I never received a reassignment, and I decided on my own accord that I would retire in July.
I just can't imagine going through all that. At any rate, you're Emory's gain, so... And since my brother was also a professor at Emory until he retired last year, I kind of have a familial feel for the university, as it were. Before you ended up at the CDC, you were the head of the Allegheny County Health Department in Pennsylvania, and that includes Pittsburgh. When you got there, what remnants of Pittsburgh, the history of U.S. Steel, the dirty air, the whole problem with Pittsburgh, how much of that was still there, or how much of the fallout from it was still there in terms of the dealing with illnesses that can be prevented?
So I'm so glad you asked that question. So first of all, when I went to Pittsburgh, I had never even visited. So it was fascinating experience, and it is so shaped by its history, the health outcomes that they're experienced, but also just one of the things that I found fascinating as someone in public health is I wanted to see the poverty maps, because often our biggest health issues are in the areas where we have the densest poverty. And I'm originally from Chicago. And I will tell you, the Pittsburgh region, Allegheny County doesn't look like Chicago at all, because the poverty is all along the rivers. And this was quite surprising to me because I didn't know as much about the history. And now that I understand the legacy of the steel industry and really the demise of the steel industry in the 70s and 80s, which has left impoverished communities all along the rivers. And it sounds like you know a little bit about the region, but what was so fascinating about the county is there's something like 130 municipalities in Allegheny County. Pittsburgh's one, but there are 129 others. And at the time of the peak of the steel industry, many of these towns, you probably have heard of Braddock, for example, they were pretty booming towns, and they really had everything you could possibly want. They had their healthcare, they had their hairdressers, they had their shopping, they had their theaters, and people literally did not go into the city of Pittsburgh, right? So it's not the same dynamic that you see in the Chicago or the New York, where you have sort of the suburban ring. But what's happened over time, because they lost such a large population, Pittsburgh is now about 300,000 people. And
I think I saw something that the population went up in the last time they checked it for the first time since U.S. Steel closed, essentially.
Right. And so they lost like 300,000 people from this center, which is just enormous. So Allegheny County actually had a larger population base in many ways than the city of Pittsburgh. So, just that whole legacy. Now, I will not say that when I went to Pittsburgh, my area of expertise is adolescent medicine, chronic disease, things like that. And when I got to Pittsburgh, it became very, very, very clear, very, very quickly that environmental health was going to be absolutely a priority. And I would say for the 6 years I was there, I spent an enormous amount of time talking about air quality. We actually, as a county health department, ran all of the air quality permitting regulations. We would work directly with the EPA on those kinds of things. And during the time I was there, we still had a very large steel plant. It's called a coking facility. And coke is one of the raw materials that gets used in steel. And it is, I will say, a very dirty business, no matter how you cut it. It is I actually went and put on all the whole garb, and I went up on top of the battery and checked it out. There's pictures somewhere of me in my hard hat. And it's just surrounded by coke, and coal is very tenacious. It's very sticky. So that soot just sticks to everything. And they heat up the coal to an incredibly high, I think 500 degree Fahrenheit or something like that. And in that process, all of these chemicals come off of it. And that's what those stacks are all about. So the higher the stack, the more likely that flume is going to go out really, really high. So yes, I became quite knowledgeable about air quality, quite knowledgeable about the impact of air quality, about pollution controls in the factories, and also about the limitations that a health department has in terms of being able to crack down on industry. So we had fees and permits, but I think that was sort of part of the business that was expected. And even while I was there, U.S. Steel had promised to invest about $2 million into the coking facility to make it better. And my understanding, because I left after about 6 years, was that they did not, in fact, do that investment.
I did a series for Westinghouse Radio. This was umpteen million years ago, after U.S. Steel closed and when they were beginning to clean up the city on air pollution. And it was an environmental series, and this was the place we went for air pollution.
There are two steel mills in particular. U.S. Steel was what do they call it, horizontally, vertically integrated, in that there were multiple plants that went all the way from the coking facility to actually the facilities that made the refrigerators and things like that. And, the Edgar Thompson plant was still active, and the coking facility was still active. The biggest polluter generally was the coking facility because it has these it had like 10 batteries, I think. Now, I do want to just say, though, that they have cleaned up the air to a large extent. And, you know, if you hear the stories historically of Pittsburgh feeling like night during the middle of the day, or what they would call the two-shirt situation, where people come home midday and change their white shirts because they had become so dirty, their cuffs and things like that. It doesn't look like that anymore. Now, what you can still do is you can still smell the smell of coke, often when there's an inversion at a certain level. So I actually lived on a hill, and if you came out in the morning, you could smell that smell. And then if you walk down this hill, it would disappear. And then by midday, usually the inversion will lift. I mean, you're talking about a valley where 3 rivers come together.
Yeah.
So you have an unfortunate scenario, geographic scenario, which essentially captures the air. And under certain meteorologic conditions, it can be very problematic. Now, all of that said, you know, every year, the American Lung Association does its State of the Air report. And every year, Pittsburgh, even though it improves generally, is still on one of the top, you know, areas for ambient air pollution. And the big one is something called PM 2.5. But there are other, you know, challenges, ozone, things like that, in this region that I think are still attended to. And as a result, there has been a very large investment from the foundation community, which is very large in the Pittsburgh area, in advocacy around air quality. And so as the health department, we were often the recipient of some very loud and vocal opinions about what we should and shouldn't do. And I think one of the challenges of being an agency that is, you know, very connected to the rules and regulations of the EPA and what the standards are, we had to walk a line, I think, between being as aggressive as possible, but also recognizing that there were limitations to what we could do based on the science, based on what the EPA had as the clean air standards. And so my understanding is shortly after I left, and hopefully be in part because of some of the work that we did at the health department, they did meet the clean air standards. That doesn't mean that they don't have work to do, because they still do. And as long as that's plant there, it will be a challenge because, as I said, it is just, you know, today, if they were going to build one of those plants, they would never, ever build it in such a populated area. It just would not even be a consideration.
Well, I think my emphasis was on the laid off steel workers, because I mean, this was a very long time ago, way before you went. It was like the beginning of my career. And I remember going up into the hills and talking to these Polish heritage steel workers, and it was more about, you know, where are we going to find a job, and, you know, that kind of thing, that it was still this big problem, and some of their history and how they got into it. But I do remember that at that time, the medical, there's a big hospital there that was becoming prominent as an employer, and there was this changeover going on.
Absolutely. They call it the meds and eds. And they shifted very much from steel. In fact, I think when I left, maybe U.S. Steel only employed about 3,000 people. And U.S., you know, and UPMC, which is one of the big healthcare systems, there's 2 big healthcare systems, and the University of Pittsburgh were the largest employers in the region. So, and US UPMC is much bigger than just Pittsburgh. It goes across multiple states. It has, you know, presence in other places. Right. So yeah, Pittsburgh went through some really fascinating changes. And I think also in large part because of the number of really prominent foundations that are there. They also invested in the arts. They invested, you know, remember Carnegie, as they say in Pittsburgh. And so there was I think there were at least 7 museums in that town, which was kind of amazing. There were 3 large, like Broadway-based kind of theaters that were there.
Wow.
They had actually, you love this, they had a drink tax, and most of the tax actually went to support the arts,
Wow.
which is
That's
pretty
so
amazing.
cool.
Pretty amazing. So,
Yeah.
I think that's a really, and all of those foundations, some of the really big foundations, R.K. Mellon, the Heinz Foundation, they invested in their communities. So, they don't spend their money all over the nation. They really do spend it in Pittsburgh. And I feel like that has really helped Pittsburgh to be quite the vibrant place that it is today. And I still keep in touch with a lot of people there and sort of know what's going on. And a friend of mine just became Pittsburgher of the Year. So, there are a lot of amazing assets. You'll love this one. I just spent some time in Cleveland last week because I was helping one of the health departments there. And they were like, oh, well, Pittsburgh, we're not quite like Pittsburgh. And, there's always this rivalry between Cleveland and
Yeah.
Pittsburgh.
Yeah. Well, I'm from Boston, so like that part of the world is like, another world. But let me pull you back to the main subject here of preventable diseases. So, if you had an air pollution situation still, there was no way to prevent it except to stop that, and there were limits to what you could do. So, as a county health department, given what you've told me, what could you do to try to cut down on these diseases, to cut down on the money spent on these diseases as they progress?
So I think it's really important in the area that you're talking about, which tends to have a lot to do with respiratory conditions and cardiac conditions. We also have smoking.
Mm,
And smoking in the Pittsburgh area when I was there was still way too high. It was definitely above the national average. I think I want to say a time, and I may get the numbers wrong, maybe 19% of the population was still smoking. And unfortunately, the people who were smoking were often in the same areas that were exposed to the air pollution. And that made it extremely difficult to disaggregate the impact of air pollution versus smoking on the population itself. And so part of what the health department was doing was really focusing a lot on trying to get people to stop smoking, as well as obviously to do the regulatory work that health departments do with regard to air quality. And I think to try to warn the public when there were days that were particularly problematic. We did have a big challenge when I was there, which is there was a big fire that brought down a lot of the pollution equipment
mm,
at the big plant at this coking facility. And as a result of that, issuing warnings. But as you said, there's not that much you can do. Stay inside, don't exercise, whatever. But there's really not much you can do. And you can only imagine that in those areas where there is that legacy pollution, right, in the soil, the property values are not very high. And
yeah.
so it's very hard for people to just say, oh, I can't just move. I can't just get up and go somewhere else. Now, while I was there was also another facility that was closed and that they left. And we were able to, it was on Neffle Island. And we were actually able to see changes in things like asthma, visits to the emergency room after the closure of the plant. So I think that the message more than anything around that was to just keep pushing the issue of air pollution and how important it was and how important these controls were. And I think I just saw recently that they upped their fees again, which, whatever you can do to disincentivize the polluters is a good thing.
Yeah. So, okay, what did you take with you then when you went to the CDC that was applicable on a national level? And in that sense, we always talk about the national level, but isn't the national level a collection of Pittsburghs in a sense, or whatever? Because you have to exactly what you've been talking about and more you have to deal with all over the country and their particular circumstances.
So when I went to CDC, I had spent my entire career at the local level. So I spent a very long time in Boston and worked for the Boston Public Health Commission and worked for the Cambridge Health Alliance before I went to Pittsburgh. So that is really where I loved working. I loved working in community. I could really understand. I really felt like I was having an impact, and we worked a lot in a whole variety of prevention spaces, obesity to air pollution, to violence prevention, to substance abuse prevention. We did a lot of activities. When I went to CDC, I hoped to really get CDC in many ways to truly understand what was going on at the local level. And to try to shift, for example, we did a lot of grant making at CDC. 80% of the dollars that we had in my center went out to the field. But it's not always easy to sort through a CDC proposal and figure out how to do it. And so something like making that an easier process, but really having front and center the local public health needs was my mission in a lot of ways in going there. I think the second area is that at the level of the CDC, at the level of Washington, you're often talking about shifts and changes that are either regulatory in nature or policy driven. And people don't always really understand the impact of that on the field. And I felt like that was a skill set that I could really bring to leadership, which was a very pragmatic and practical approach to how things we were doing were really going to impact the field and whether or not they would be helpful, or in some cases just create more chaos, to be honest.
Were you there? You were there for 6 years, right, as head of that agency. Was that long enough to see anything coming out of these grants and these plans that you made? I mean, that you could. I would assume that some of this we have some scientific knowledge, like you said about the smoking, for example. We know what that does, but there are other things that are mixed, or we don't really know, that might be individual, because obesity goes in so many different directions and things like that. Did you come out with any kind of knowledge of what works and what might work everywhere, where you could get down to the inner city levels, the rural levels, and deal directly with smaller groups of people rather than this is the plan for Chicago or this is the plan for Boston? Because I know growing up in Boston, it was many places.
Well, I think that one of the biggest challenges is, well, first of all, let me start by saying I walked into CDC in 2019, okay? And the first thing I remember saying to someone was, oh, that problem going on with e-cigarettes and people's lungs? Is that something I'm going to have to be involved with? Thereupon spent the next 4 months dealing with what was then ended up being called a volley. I then got about 3 months, and then we had a pandemic.
That's right.
Okay. So a lot of the things that we did in our center that I do think really make a difference were somewhat curtailed during the pandemic, in part because of the type of mitigation strategies that went on. So, for example, there had been a lot of progress being made in cancer screening, okay? Particularly in colorectal cancer screening, which was something we've been really pushing for a long time. And we were seeing downward trends in cancer death. Now, those continued, but we saw a real decrease in screening during the pandemic. My guess is most of that had to do with people's not being comfortable going in to see the doctor during that time. Or many healthcare facilities basically couldn't handle anything except the emergency that they were dealing with. So we saw a real decrease in people using the healthcare system. The second thing is we actually saw people increasing their eating habits and probably gaining weight during the pandemic. We saw changes in cardiac outcomes. We think partly because people got COVID were at higher risk for getting cardiac problems.
Mm.
And if they already had a cardiac problem, and then on top of it, they got COVID, there was a likelihood that they could die of a heart problem. And, the way we understand our vital statistics in terms of what people die of is what the coroner puts on the death certificate. And that tells us what somebody died on. So we were seeing downward trends, in many of these areas, diabetes, things like that, heart disease. And then we saw this uptick during the pandemic. Now, from watching the data, it looks like most of that stuff is returning to pre-pandemic baseline. But, it takes a while to sort of know what the impact of that pause, caused to the American public. Now, the other thing is we did a lot of work with specific populations, right? Because you can't, we don't get enough money to give everybody the exact same amount. And so what we often do in public health is we identify the areas where we have the highest problems, the highest risk, and then we really try to focus the attention of the states on those areas.
Right.
And I think part of that is making sure you have folks who know those communities, who can reach out to people in an appropriate way. We, for example, during the pandemic, put a lot of our resources into community health workers and getting them off the ground so that they could make the connections between people and getting their health care. And we also saw that those kinds of things did get people into the care that they needed, really through that very hands-on, important connections, I think, that are being made. We also continue to see a downward trend in tobacco, particularly among youth. And we had seen that real uptick in e-cigarette use, and then we saw a downward trend.
Oh, that's good. From what I've read, there was a lot of distrust in health professionals in general that came out of the pandemic, particularly among the people who probably needed to see a doctor or a nurse practitioner or somebody on a regular basis. Has any of that abated as far as you can see? Because it seems to me that public health is basically that you have to bring it down to the level of the individual person. Smaller centers in neighborhoods rather than major hospitals that might not even be close to you to get to. And that you have to build a trust in the professions themselves when perhaps handed down to you has been a sense of mistrust for one reason or another. Did you, and the pandemic was the perfect proof of that.
I don't know that we've seen an increase in trust, and I don't think that the increase in cost is doing us any favors, or the loss of insurance that people may be experiencing now, in terms of the Affordable Care Act. The other thing is we have a big demographic shift going on in this country with people over 65. Mm-hmm. And I feel that those people are using the healthcare system. They're living longer. I think the average period of time one lives, if you make it to 65 without a chronic disease, is like another 20 years. And even if you have a chronic disease, you probably are going to live another 10 to 15 years also. And think about the demand, particularly on areas like primary care, where physicians are not going into that field. They're leaving the field. They're retiring from the field. They don't feel that their work days are particularly pleasant. Mm-hmm. That was my area of expertise, was primary care, and I still do some practice now. And it is not easy at all. There is a lot of, there's a lot of electronic health record stuff you have to do, a lot of billing stuff. You don't get to spend countless time with your patients.
Right.
And I think that those are the kinds of things that make it more and more difficult for individuals to feel really connected to their providers. When you look at quality measures, and this is not my area of expertise, but I do think that when you look at Press-Ganey results, which is what they use in healthcare to sort of look at it, generally people like their doctors, right? If they actually get to see their doctor, they're pretty happy, but it's the process of getting to the doctor. Mm. It's, how to navigate that system, how to get an appointment. And I just was reading something in Boston, and you're a Bostonian, that at Mass General, literally can't get an appointment with a primary care doctor. They
Wow.
just have enormous waiting lists. And now they're introducing AI to kind of help with this gap. And of course, the primary care doctors are like, well, if you would just think of us differently, if you would pay us more, all these things. We're not doing a lot in the primary care realm to really incentivize a strong primary care structure. And I do think when you think about public health writ large, that access to healthcare is part of this challenge, right? And so if people do not feel that they can get the kind of access they need, then the question is, where are they going to get their information?
Yeah.
And, it's easy to say, call your doctor, but I don't know about you, it's pretty hard to get your doctor.
Yeah.
And so I think that's led to people going onto chat rooms, social media, thinking about, and I think that means that it's very ripe for all kinds of information, disinformation, real information, all kinds of things. Now, we know, for example, for a very long time, American public has been spending a lot of money on what one considers non-traditional care. This has been going on for a very long time, and it's probably amplifying now as people feel like they're either cut out of the healthcare system or, as you say, don't trust the healthcare system, don't feel that they can get the kind of information that decreases their anxiety. And I think that those are real challenges for those of us in the healthcare field these days. I will tell you, I spent a lot of time with folks in the field of public health, and trust is about one of the number one things that everybody is talking about. How do we rebuild the trust that we experience has been lost, perhaps not starting with the pandemic, because there was a lot going on before the pandemic, but perhaps culminating with the pandemic.
Well, it's very true. I'm just thinking as you're talking to my childhood, um, we could walk to my pediatrician's office. There was a neighborhood. I don't know about more advanced care. I only remember as a child, but get to my pediatrician. I broke my arm at school one day. They didn't send me to the emergency room because they didn't know that I had broken it. And my mother walked me down to the pediatrician, and he said it. It wasn't a big deal. He has an X-ray. And that's what I remember. And I know, when you walk around the streets of Manhattan, for example, every other street level office in these more expensive office buildings on the Upper West Side and the East Side are a doctor's office. There are a million doctor's offices of all kinds in New York City at street level. And yet that you probably are going to wait a month or 2 months or 3 months to get an appointment with those doctors if they're yours. I mean,
And I think
I,
this is a lot of people, if you have money, people are doing something called concierge
oh,
medicine, where you
yes.
actually pay an extra amount and you then get incredible access. But the doctors only have a small cadre of patients, like maybe 400 patients. And now we're seeing this thing called direct primary care, where doctors don't even take any insurance at all. And they charge you essentially a certain amount every month.
Yes.
So I think that the healthcare system itself is going through a lot. Now we've got the public health system going through a lot. And I think this is causing some of the major challenges that you're talking about now in terms of how people feel about the healthcare system, whether or not they trust the healthcare system. But I do want to bring us back to public health, because I think one of the beauties of public health is a population-based approach. It's not all about what happens to the individual. It really is about what do we need to do at a population level. And
Uh-huh.
many of those things are like no smoking areas, or the regulatory forces that we just talked about with regard to air quality. And we're sort of in a place right now where people don't like that so much. They sort of feel like, I want to make my own decisions, and I don't want this public health group telling me what to do. And those tools are some of the most effective prevention tools that we have in public health. If you look at the history of public health, if you look at everything from sprinklers in houses to prevent fires, right? All of that was done at a much broader population level, water quality, things like that. But we are definitely in a time right now where I think the focus on the individual and individual choice and individualism is making that kind of population-based efforts much more challenging.
So, what do we do? Let me bring it back to something that bothers me a lot, which is maternal health, maternal deaths, particularly among Black women, which are, I think, twice as many as among white women, if not more. But that has come down a little bit, I believe, in the last year that I saw figures for, which was 2023. But it's still like double, triple other countries with state-run medical systems, which of course we don't have. Um, how do we get to that? Because again, you're coming back. If you don't get the proper care during the pregnancy period, and you use like a neighborhood midwife when you're having your baby, and she may be very good for what she knows, but it's not what a doctor knows. I mean, how do you get around that? And that coming back to trust, well, I don't trust the big hospitals, you know. I know someone who died there, whatever. How do you do this?
Well, one of the efforts that we had done while I was at CDC was we had gotten resources to provide each state with the ability to create a team of people. It's called an MMRC, Maternal Mortality Review Committee, which would then, because I agree with you in terms of the numbers, but ultimately they are quite small, and therefore you don't have a huge volume of data to look at. So the strategy here is to look at individual cases and to try to understand what happened and are there strategies to prevent this from happening again.
Mm-hmm.
So we have seen a number of states do this work, look at what has happened, and then create new protocols or new procedures to ensure it does not happen again. For example, one of the big efforts that went on was to expand the time that you get postnatal care from what was historically 6 weeks to an entire year. That's a pretty big deal. Medicaid was paying for that. I can't remember if it was like 42 states. I mean, it was a lot of states that adopted this, right? Now, the devil is always in the details. And the question then is, are states actually implementing it? What does it look like? Because we also find that a lot of women, after they have their babies, are very focused on their child. They go to the pediatrician, but they don't take care of themselves.
Uh-huh.
They don't go back for their 6-week visit, yet alone going to their family medicine doctor or their nurse practitioner or their PA or their internal medicine or whoever is taking care of their health. And I think that's one of the biggest challenges is that people are busy, they're trying to adjust to a new child and the challenges of taking care of themselves. Because what we have found is that a lot, maternal mortality, a lot of it does happen in the very, very close period of time after the child's born.
Right.
But in a longer period of time, if you look that year out, most of it is connected to things like chronic disease, heart challenges, but also substance abuse. And so those are things that if the person is not connecting with the healthcare system and nobody's really looking out for them and nobody's recognizing that they had hypertension, for example, makes it really difficult to intervene. So I think that that tells you a little bit about from a policy perspective, but again, how individual offices transition those women, work with them, how they acknowledge or recognize that they might have something that they need to attend to, how we make it easy for that to happen, I think are all important areas to be looking at, not to mention getting rid of any biases that providers may have, right? So that we take what people tell us at face value very seriously. But these MMRCs was something I was personally very proud of because it did give states an expert group of people from a variety of places to really examine these scenarios and understand what they could do differently.
Is there any thought, um, going way, way, way back, and this would have been in the cities, which had very definite neighborhoods. There used to be like public health nurses that kind of went to people's homes and and found the problems and helped them take care of them. Is there anything, any kind of outreach like that anymore? I mean, it's almost like a social worker, but it's for health purposes, where you could be after your 6 week visit or whatever visit, we could get you to come to the doctor for. You could be kind of handed off to now these are the people who are on your team, and if you don't come to them, we're going to find you and we're going to help you. Something like that, because I think, even if you could build the trust that way on an individual basis. I don't know. We're such a big country. Our cities are so big. Our rural areas are so spread out. Is that even feasible? And could telemedicine maybe pick up some of that? So I'm
So
just throwing this as, out.
there actually are a lot of programs. In fact, there's a program that comes out of HRSA called Healthy Start, and that did focus on making sure that women had home visiting. And I can tell you in Pittsburgh, we actually had a home visiting program in our health department. One of the challenges, though, I will tell you, was that some of the women who probably might have benefited most did not want someone coming into their home.
Mm.
And there is a lot of challenges to feeling like I don't want someone to report me. I don't want my children to be taken away, or I don't want anyone coming into my house. And so that was often the people who took the service had better outcomes to begin with. But there was a compilation of programming both from the health department and also from the human services department that did provide home visiting. It was not universal, but it was relatively good. And I think a lot of cities in particular do have that. You are absolutely right. Rural health is a huge challenge. Community health workers have also been encouraged. There's folks called doulas you may have heard of.
Yes.
Many health systems have brought on doulas to help with this. There are home visiting nurses. There's a whole program called Nurse Family Partnerships that's evidence-based that a lot of states and counties utilize. But what it is not is it is not universal. We do not live in a country right now where every woman who has a baby is guaranteed a year of, home visitor, for example, which some countries, have done. But more importantly, I think the challenges around future funding, around making sure that these continue to be available is helpful. But then it also is voluntary. Mm-hmm. And it is not, it is not something that you have to receive in terms of an individual. It is totally something that, if I want it or if I don't want someone to be coming in. And I feel like those have been, I've been involved in the home visiting world for a long time. And I think that's always a question, right? And now, yes, we are moving into these strategies using telemedicine. And there are practices that are actually giving out, a pad to people so that they can actually encourage that. And I think if you know that there is a new program right now for rural health that's going, states have been given a good chunk of change to start to really implement new strategies. I think many of them are using telehealth strategies and putting together the technology that's needed. But remember, you can't do telehealth if you don't have broadband and you don't have the internet, or you do not necessarily have the skill sets to be able to feel confident in using that kind of technology. Right. So I think we still have hurdles, but we are definitely, I think, moving in that direction.
Is there a role for private businesses? I've done a couple of interviews with small startup high-tech businesses that are helping, that have made, one of them had a contract with Medicare, for example, for helping people find nursing homes that suited them or something. I mean, they were very narrow areas, and they were really kind of experimental. But it sounded like a good idea for the couple of people that I interviewed. So is there the role for the private industry, and the fact that they are often more innovative than government can be?
I would say absolutely. I think that there is certainly a lot going on in that space right now. There is a lot going on in the AI space in terms of how that fits into healthcare. And I think that there are going to be some phenomenal innovations that come from this. One of the challenges is connecting the dots between whatever this new technology is and the implementers who are going to actually try to get that out there, to distribute, to disseminate, to explain, and to build the trust in these things, right? So, sometimes I think like we have what they call a digital divide, right? Which is that there are a group of people who do not feel confident with a interactive cell phone or anything like that, where they still want to talk to somebody. They still want a human voice.
Yeah.
And then there are younger people who feel like, no, I want the app. I mean, I talked to one guy and he said, yeah, I went to this particular practice because I wanted an app.
Yeah.
I wanted to know that I could just go on there really quick and and get what I wanted. So I think we're going to be seeing an evolution of this, and we're also going to be finding out more and more spaces where AI is considered helpful and spaces where it's considered a distraction or it's considered something that actually separates providers from the patients, right? So I think it's important to remember that AI at this point in time doesn't really have any judgment.
Yeah.
It doesn't have values.
Yes.
I think one person said to me, you've got to think of it as a really good assistant, but you still have to add that human touch. And I think wisdom is going to become more important as time goes on, because
I hope you're right.
you can program the AI to get at the actual content. But I do think, particularly when you're thinking about communities where it is very challenging to get people to people, right? Or to get people to resources, that we have to come up with really interesting strategies for being able to make that connection.
All right. Let me kind of wrap this up here because there's a lot more I wanted to ask you, but it turned into really interesting directions. In the near future, which is basically what most of us can look at, I don't really want to hear about 40, 50 years from now. I want to know about now or the next 5 years. What do you see happening in the public health area that's going to cut down on, and we haven't even talked about adolescent health, but specifically cutting down on the problems that we have now, the health problems that we have now, to lump them all together, taking that money that we're going to save and putting it toward something better?
So first of all, I want to say I'm not sure we're going to save any money. And part of the reason is that we have this enormous population of people over the age of 65 who are going to use the healthcare system. So I don't think you can, even if we were to be extremely successful on the prevention front, those costs are still going to be there as this population moves through the next 20 years. So I think to think that we're going to save a lot of money is not accurate. There are a couple of big things that I think are happening, and one of them is the fact that we have this elder population going on, and people are going to want to live their healthiest selves as long as they possibly can. And I think it's going to be important for the healthcare, the public health environment, to be thinking about, perhaps in this case, we call it secondary prevention, how to prevent falls, how to make sure people have places where they can still be active. All the things that are going to be important to this population who are, by the way, they have a reasonable amount of money, not all of them, but a good chunk of them do, and they really do want to be healthy. And so how to help them live their best lives. So I think that's really important. I think there are some really important medical things that are going on treatment-wise. Probably the big one is the GLP-1s.
Yes.
I don't think we can underestimate how that is going to be impacting things like obesity. Now, unfortunately, the GLP-1s do not prevent obesity, at least not at this point in time. So it is a secondary intervention. And I really hope we do not take our attention away from prevention, which tends to be about food and physical activity and reducing alcohol and reducing cigarette smoking. Those are the four big ones that we really need to continue our focus on if we want to see these preventable conditions decline. So I feel like those two, and then you talked about it, the technology is really having an enormous impact, I think, across all of health, all of public health. And all of these things I'm talking about, they're not going to stop or, because of a change in administration. They are all happening around us. And I feel like we are trying to adjust to that in terms of thinking through the next phases. So in the public health sphere, lifestyle programming, like what are the ones that work? What are the ones that don't work? The whole area of diet, there's so much controversy in terms of what it is you eat and how we get people healthy, non-ultra processed foods so that aren't so expensive that they can't, enjoy them. And I think those are some of the kinds of things that we really are going to need to be thinking about in the public health realms. I also really feel like this conversation that we've been having about healthcare and public health and how they are working as effectively together as possible is really, really important, right? We have seen enormous impact because of some of our regulations around smoking. Mm. Nothing can make that kind of a dent. An individual provider cannot make that kind of a dent in that particular behavior. They couldn't make a dent in, that seatbelts have made or that airbags have made, right, in terms of reducing death. And I just think we need to be seeing these things as working as effectively together as possible.
Well, I think we'll leave it there. I think that's a hopeful ending. To some extent anyhow. And I also think that there has to be an element of self in this. I mean, you can't say to the government, you do it all. You can't say to the medical profession, you do it all. There has to be a true interest by each individual in their own health. And that, I think, is the challenge, because that's so individual. What's going to get to that person? And that, I would say, is the next step.
Yeah, and I think one of the challenges has always been that the commercial industry is really good at getting information to people and convincing them to buy a particular product or to do a certain thing. And I think the public health sector needs to learn how to do that more effectively.
Hire some young people coming out of your classes at Emory who are really good with TikTok and give them a free rein. Right. Seriously. I look around all the time and say, I need a teenager to help me with the technical part. But I mean, I'm only half joking. That's where it is. Mm-hmm. If you want to get to people when they're young, that's where it is. And if you can get to them when they're young, then maybe they'll build habits for a lifetime.
Agree.
All right. Thank you, Karen Hacker, very much for being on the program.
You're welcome.
Dr. Karen Hacker has both an MD and MPH and is an adjunct professor and health policy fellow at Emory University in the Rollins School of Public Health. She's the former director of the National Center for Chronic Disease Prevention and Health Promotion at the CDC from 2019 to 2025. Dr. Hacker has over 2 decades of leadership experience in the public sector, serving at the city, county, and federal levels. Her expertise spans public health, policy, healthcare, and research. Prior to the CDC, she was the director of the Allegheny County Health Department in Pennsylvania. She's also widely published with over 100 peer review articles and an expert in community-based participatory research. And there's more that you can find in the show notes. Now, our April episode has unexpectedly collided with the joint Israeli-U.S. attack on Iran, which began on the last day of February and which resulted in the death of Iran's 86-year-old supreme leader, Ayatollah Ali Khamenei. A few days later, I had an interview scheduled with my April episode guest, Dr. Ron Ballecer. He's a physician, scientist, and executive who's the Chief Innovation Officer at Clalit, Israel's largest healthcare organization. He also works with the Clalit Research Institute, the World Health Organization, and other organizations and universities in Israel and beyond, planning, developing, and implementing novel AI solutions in healthcare. Somewhat unbelievably, Dr. Balliser and I were able to have a perfectly normal, uninterrupted Zoom conversation. You'll be fascinated, as I was, and perhaps just a little fearful, as I was, with what is already embedded and perfectly normal at Clalit, which serves more than half of Israel's population. Episode 43 will drop on the third Tuesday of March. As you know, I schedule one new podcast episode a month. If you enjoy the podcast, please follow us or subscribe, and always share. The video version's on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. I'm Stephanie Shelton. You take good care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.